Auzu billahi minash shaitanir rajim. Bismillahir Rahmanir Rahim. So, with the grace of Allah Almighty, today we're gonna start with the subfertility module properly. Okay. So, the first question, I'm gonna complete the syllabus in question answers form so that you can remember the points of guidelines. I'm against passive reading. That is something that you yourself do. So, that's not something that I'm gonna do. So, when are you going to investigate a couple for subfertility? Okay. So the scenario is that they don't have any risk factors and they are married for 6 months. They're trying to conceive. They are married for 1 year and they're trying to conceive, or they are married for 2 years and they're trying to conceive. So when are you going to investigate them? Kindly, yeah, participate in the discussion properly so that we can get proper answers. Otherwise, there might be an issue. Let me just adjust the camera, guys. Give me 2 minutes. There's some problem. Okay. Here it is fixed now. So, what do you think is the answer to that? Okay, so there's one simple scenario that you are going to investigate a couple for the risk factors and the issues when there had been 12 months of unprotected sexual intercourse, that is OPSI. I'm going to use the term OPSI, or 6 cycles of intrauterine insemination, that is IUI. Okay. At this point, you're just going to carry out the investigations. Please write it down. You're not going to, do it with the intention of treating. You're just doing it for the scrutiny that there might be an issue. So these are for the low risk cases. Okay. But for the high risk cases, the duration shortens. For the high risk cases, you are going to carry out the investigations rather earlier. So you're going to carry out the investigations at you're going to half of the time. So this 12 months, you're going to carry out them after 6 months. So what are the high risk cases? When the female is more than 35 years old, when you know that there are some risk factors, the patient might be undergoing chemo, the patient has a known CA. So in these scenarios, you're supposed to carry out the investigations after 6 months of OPSI. Okay, so this is a very important thing. Now, so you are going to carry out the investigations in which you're going to perform the history and examinations. Now, can please someone tell me that what is the first investigation for subfertility assessment? Okay, I have told you when I'm going to carry out the investigations, right? After 12 months of OPSI for low risk cases or 6 cycles of IUI, or after 6 months of OPSI for high risk cases. And what are the high risk cases? When the age is more than 35 of the female, or there's a known C at the patient is under one of the partners undergoing chemo. So, the first investigation is going to be of the male partner. That is going to be the HSA, the semen analysis. And a very important point is that almost it's a rough estimate. Okay, don't memorize this. I will share the spreadsheet of the exact numerical values. Please try to just understand the concept in these sessions. So I think almost 33 to 36%. Correct me if I'm wrong. Is contributed by the male of the infertility, and out of this percentage, almost 60 to 66% is idiopathic. Okay, so now does someone knows the correct values of HSA? They're very important. They're ones that are given by NICE, and then there are ones that are given by the WHO, and you should know both. There's only a little bit difference between both of them. Wait, I need to get a new page. Okay. So the values are that the volume should be more than or equal to 1.5 ml. This is for the volume. The concentration is 15 million per ml. The number is 39 million per ejaculate. Motility. So motility is taken as progressive and total. Total is 40%, progressive is 32%. Any one value will be given in the question. Vitality is 58% and morphology is 4%. Now, in the WHO criteria, this value has been changed by 0.1%, that it's 1.4 ml. This value 58 is changed to 54%. But only this minor difference in the morphology. Okay? Now, you carry out the HSA, and the HSA has an abnormality. What are you going to do next? Going to start treating for the abnormality? If the patient is having oligospermia on one HSA, the first one, let's say the first HSA gives oligospermia. What are you going to do? Please answer. Yes, you're going to repeat it. When are you going to repeat it? You're going to repeat it after 3 months. You're not going to repeat it right away. You're going to advise repetition of HSA after 3 months. But in which conditions you are going to repeat it as soon as possible? There are some conditions in which you are going to repeat it as soon as possible. What are those conditions, guys? When are you going to repeat it as soon as possible? Very good. When there is a severe abnormality. Okay, for example, there is azoospermia, or there is severe oligospermia, or there is gross teratospermia. In these severe abnormalities, let me write down those abnormalities. So when there is azoospermia, no sperm, this is a gross abnormality, no sperm at all, or there is severe oligo, or there is severe teratospermia, like the abnormally formed ones. In that case, you're going to repeat as soon as possible. Otherwise, you're going to repeat it after 3 months. Okay? Very good. Now, my next question is how we're going to manage accordingly. So, as I was just discussing the concentration, let's start with each parameter over here. Okay, then we'll move on towards the female factors. Okay, because HSA is the first investigation, so I'm discussing the male factors first. Okay, so over here, I want you guys to stay attentive and answer the questions, otherwise there won't be any benefit of a live session. Okay, so now let's talk about the concentration. This one, can someone classify oligospermia? 15 million per ml is normal, I know. So how are we going to classify it, the abnormality? It's mild, moderate, or severe oligospermia. What are the values? Okay, so mild is less than 15, but till 10 to 15. Moderate is less than 10, but more than 5. More than 5. And severe is less than 5. Please, guys, this is a very common question trap that they have written that the concentration is 5 million. No, less than 5 is severe. 5 million is not severe. What is 5 million per ml? It is moderate, because you need less than 5 for severe oligospermia. Okay, and the treatment is for severe oligospermia that is less than 5. We have to perform intracytoplasmic sperm injection, that is ICSI. Okay, and for the moderate and mild ones, you are going to go for IVF. Okay, they also say that for the mild ones you can also do expectant management, but we have the option of IVF. But remember that for severe you have ICSI. If only isolated oligospermia, I'm only discussing isolated oligospermia, I'm not discussing other abnormalities along with that. Okay, so Now, the next thing, okay, one more question I want to ask you guys. So, if you perform the first semen analysis, and on the first one, the value is severe oligo, what is the next step? First time the investigation has been done. Very good. You're going to repeat it as soon as possible because this is a severe abnormality. You're not going to wait for 3 months. You're not going to perform ICSI right away. You have to repeat every first specimen analysis that is abnormal needs to be repeated. The question is that when to repeat after 3 months, which ones, and when to repeat as soon as possible. This is the question. Okay, and when there is a gross abnormality, for example, there is severe oligospermia, there's azoospermia, there's teratospermia, and then in these scenarios you're going to repeat it as soon as possible. Okay, otherwise wait for 3 months. So now we have understood oligospermia, how we're going to manage it, what is the classification, what is the treatment. Okay, now I'm going to discuss one more thing. It's a scoring. Okay, so please pay attention. Everyone pay attention, please. I'm going to ask a question then. Oh guys, I need a new page. Wait, I should get myself a nice whiteboard. Okay, so on the analysis, 2 or more analysis, which means one, we have repeated it now. 2 or more analysis have more than or one abnormality which is less than 5th centile of WHO mild male factor infertility. What is mild male factor infertility? And I'm going to treat it by IVF. Did anyone understand this? Because I didn't quite get it for the first time. It seems difficult, this definition of mild male factor infertility. I want you guys to read up on it. You should know this terminology for your Mrcog exam. Mild male factor infertility. Okay. So for this one, when there is one or more abnormality on the analysis, it's mild. Okay, now please understand the score. When there are 3 mild factors, 1 plus 1 plus 1. One is oligo, moderate oligo. One is, let's say, morphology is 2%. And the third one is, let's say, volume is, not the volume, let's say motility, and not even motility. For motility, we need ICSI. Oh God, I'm finding it difficult to find an example. Let's say, okay, yes, let's say vitality. Vitality is 40%. So these are 3 factors now. Whenever there are 3 factors which are considered themselves mild, the treatment is going to be ICSI. Okay. Otherwise, when there are 2 factors, when there are 2 out of 3, or let's say 1 out of 3, you're going to do IVF. But when there are 3 out of 3, you're going to do ICSI. So what are the indications of ICSI? Please note these down. This is a very important question and student mix it up. When the 3 out of 3, or there is azoospermia, no sperm at all, that's a severe thing. Or when there is severe oligo, what is the value? Less than 5 million per ml. Do we get it? See, it's really simple. So I'm going to ask you guys, when are you going to perform IVF and when are you going to perform ICSI? Let me tell you the truth, you can't get through this without practice questions. But still, I'm trying to, help you get a concept. We'll definitely move towards the practice questions later. Okay. So, what are you gonna do in case of azoospermia? I have told the management of oligospermia. Can someone repeat it for me, please? Let me ask questions. Okay, okay. What is severe oligospermia? Can someone define it, please? Exactly. Severe oligospermia is, hurry up, less than 5 million per ml. What is the treatment for severe oligospermia? What is the treatment? ICSI. Why not IVF? Why not IVF, guys? Because it's a severe thing. And when I'm going to do IVF in the remaining types, what is the moderate one? 5 to 10, we're going to do IVF. What is the mild one? 10 to 15, you can do IVF. Very good. So you guys have understood. Now, for azoospermia, what you need to do is another page. First, you need to get another page. My whole notebook is gone. It's just, wait, just okay. So who's gonna tell me? Yes. So in case of azoospermia, you need to do the FSH and the testosterone levels to find out why is it like this. Okay, FSH and testosterone levels. So there are 4 combinations that you're gonna have. You'll have to memorize this for the exam, guys. Understanding them, FSH and testosterone are normal. What does this mean? This means that there's an obstruction at the end. Okay, there's an obstruction at the organ level. Maybe the vas deferens are obstructed or absent. So what you're going to do in case of when the levels are normal and there's azoospermia, it directs you towards diagnosis of obstructive azoospermia. And in this case, you're either going to perform an ultrasound of the testicles, you're going to refer to a urologist. Okay, urologist win over here. So the patient is going to go to a urologist right away. If the question does not give you an option of referring to urologist, then you're going to pick ultrasound. Okay, remember that ultrasound, referring to urologist is greater than ultrasound. Do you get it? Next, FSH is low and testosterone is also low. What is this? What is this, guys? Hypogonadotrophic. The gonadotrophin is less. When does it happen in Kallman syndrome? FSH is normal. Testosterone is low. What is this? Spermatogenesis failure. Okay. For this, you can also, aspirate and check if there are any sperms in the testes. The fourth one. FSH is high. Testosterone is low. This is basically very dangerous because this is total failure of spermatogenesis. And the mnemonic for this scenario is KEN, which is Kallman syndrome and Noonan syndrome, and there's this male Turner syndrome that you should remember. That is the Y chromosome deletions. It's KYN. Okay. So guys, the basic questions that you should know is when to do IVF, when to do ICSI, what is severe oligo, moderate oligo. This was the chart for azoospermia. And then you should know that when are you going to carry out the investigations of subfertility in a couple when there are no risk factors, what are you going to do when there are risk factors. Okay. So in the next session, we're going to discuss about the female factors. Thank you, guys. How do I end this now?